Good afternoon, everybody. At the outset, let me thank the organizers and especially Dr. Bansi Sabu uh, and his team for having invited me to this grand gathering of physicians and diabetologists from all over the country and abroad. And my respect to chairpersons. We heard about the diabetes guidelines. Forcefully, we have been saying that we have to evolve. And evolution always takes place, and this can happen only with the partnership of the physician and the patient. Considering all this, we are talking of guidelines in hypertension. I'll first talk about the topic that has been assigned to me, and that is evidence-based guidelines for management of hypertension with diabetes. This has been brought out in 2014, and the question has been posed, what is the essence? This is what was brought out in 2014 in around September, October. And this was a report from the panel members appointed to the 8th Joint National Committee. This has been construed to be a JNC 8, popularly known as JNC. But let me remind you that there is no such thing as Joint National Committee report that has come out. It is only a recommendation. And so, this group of members, out of this, 2 did not agree with these recommendations, and that's why the JNC 8 did not come out. And it shall never come out because this JNC, Joint National Committee, has been disbanded. So, whatever the recommendations that they made, they said this is based only on the evidence, not on our anyone's personal whims and characteristics. And that is why it is known as 2014 evidence-based guidelines for the management of high blood pressure. I'll talk to you about from these guidelines about diabetes. I'll not go into the details of the hypertension guidelines because it will be a subject which will take a longer time, and I will restrict it to diabetes. This report takes a rigorous evidence-based approach to recommend treatment thresholds, goals and medications in the management of hypertension in adults. And there is a strong evidence to support treating hypertensive patients aged 60 years or older. This has to be kept in mind, to a BP goal of less than 150 by 90 millimeters of mercury. What we had up till now been understanding till 2013, where the third Indian guidelines on hypertension came in, we always thought that the patient of hypertension who has a comorbidity like diabetes should be having his blood pressure controlled to less than 130 by 80. But these guidelines recommended that the BP goal of less than 150 by 90 millimeters of mercury, and hypertensive persons through 30 to 59 years of age to a diastolic goal of less than 90 millimeters of mercury. Why did they come out with this? They got the evidence that this is achievable and there are less complications due to this. The same threshold and goals are recommended for hypertensive adults with diabetes or non-diabetic CKD as for the general hypertensive population younger than age 60 years. What is important to note is I think I'm going back. Then 60 years was a very important hallmark. Then they said that there is a moderate evidence to support initiating treatment with ACE inhibitors, ARBs, calcium channel blockers or thiazide diuretics in non-black hypertension. They are divided into non-black and black population, including those with diabetes. In the black hypertensive population, so the evidence showed that they responded better with calcium channel blockers or thiazide type diuretics rather than ACE inhibitors or ARB. And that's why that this was recommended as initial therapy. And there are many recommendations. I'll give you only 5, 6, and 7 recommendations because this pertains to diabetes. And recommendation 5, because what is this recommendation? There was a questionnaire given by this group, and whatever the response that they gave was deciphered into a recommendation. And the recommendation 5 dealt with the population ages 18 years or older with diabetes. Initiate pharmacological treatment to lower blood pressure at a systolic blood pressure of 140 millimeters of mercury or higher, or diastolic blood pressure of 90 millimeters of mercury or higher. So, when will you give treatment? This was the question posed. And the answer was that if the blood pressure recorded was 150 by 90 or higher, then the patient should be treated to a goal of systolic blood pressure lower than 140 and a diastolic blood pressure lower than 90 millimeters of mercury. So, when will you initiate and what level will you reach? Earlier, the recommendation was that you bring it down to below 130 by 80 and keep it at that. Here now they are saying 140 by 90. And this is the expert opinion. The recommendation was evaluated as grade E recommendations, not very significant. And this recommendation is based on evidence statement 18 to 21. As I told you, a questionnaire was given, and this 18, 19, 20, and 21 was the questionnaire where these questions were asked and the recommendation was given, which addressed the BP goal in adults with both diabetes and hypertension. And the studies used for this recommendation 5 were the RCTs, that is systolic blood pressure goal lower than 150 millimeters of mercury, SHEP, Swiss Euro trial, UKPDS, Accord BP trial, and Advanced trial. RCT also studied the diastolic blood pressure goals of lower than 90 millimeters of mercury, and the HOT and UKPDS trials. So these are the trials that they went through and came to this conclusion and gave a recommendation. Then the recommendation 6 was regarding the non-black population, and we are considered the non-black population, including those with diabetes. Initial antihypertensive treatment should include a thiazide type diuretic, calcium channel blocker, ACE inhibitor, or angiotensin receptor blocker. Mind you, in diabetic hypertensive, we say that the first line of therapy should be ACE inhibitors or ARBs because of its effect on the hypertension in a diabetic patient of reducing even the insulin resistance. And this was considered as a moderate recommendation, grade B. A very important recommendation that you can use any of these drugs, thiazide diuretics, calcium channel blockers, ACE inhibitors or ARBs, but reach a goal of less than 140 by 90 millimeters of mercury. And the studies used for recommendation were VA cooperative trial and SHEP. So these are the studies from which they got this data, and that's why they recommended of using all these drugs. And the recommendation 7, so these are the 3 main recommendations from which the trial, the recommendation, the Joint National Committee gave the recommendations. And in the general black population, diabetics, they said that should be used with either thiazide diuretics or CCB. They have not recommended ACE inhibitors and ARBs in this black population because they found that the results were better with calcium channel blockers. And this was a moderated recommendation, grade B, like recommendation 6. And for black patients with diabetes, a weaker recommendation, that is grade C. So these three recommendations were suggested, and these guidelines came into being. Now, what is the essence of this? I'll come to you a little later after I give you what is the other guidelines saying. Now, as far as the goals of treatment, there was another clinical practice guidelines that was released simultaneously when these evidence-based guidelines were released in October 2014. And these clinical practice guidelines says that for hypertension, the treatment goal for systolic blood pressure is usually less than 140, and for diastolic blood pressure less than 90. Same as the evidence-based guidelines. In the past, guidelines have recommended treatment values of less than 130 by 80 for patients with diabetes, chronic kidney disease and coronary artery disease. This was our understanding, and they were risen to 140 by 90. However, evidence to support this lower target in patients with this condition is lacking. So the goals of 140-90 minutes should generally be used, although some experts still recommend 130 by 80 if albuminuria is present in patients with chronic kidney disease. So this is the way the pendulum is swinging, and the authors, so the most important statement, giving a guideline, giving a recommendation, then they give this statement that the authors of this statement acknowledge that there are insufficient published data. So we are talking of evidence-based guidelines. These people say there is not sufficient data from clinical trials in hypertension to create recommendations that are completely evidence-based. So the essence of what the question that has been posed for this lecture is, what is the essence? This is, if we can say that there is not a clear-cut recommendations and that they are not completely evidence-based, and so inevitably some of our recommendations reflect expert opinion and experience. That means what I feel and what we see in our patients and how we are going to treat these patients at certain times. Before these guidelines came in 2014, the Indian guidelines on hypertension came out in 2013. Many of you must have got this copy, and this was brought out in JAPI. The API brought out these guidelines, and remember this is the third guideline. First and second came almost 9 and 5 years back. In 2013, these guidelines came into being, and this was endorsed by the Nephrology Society, the Cardiology Society of India, the Indian College of Physicians and Hypertension Society of India, the main areas where the hypertension is seen increasingly. And this was done by a group of 5 people from all over the country and sent to various, more than 250 physicians all over the country, physicians, nephrologists, cardiologists, and neurologists, to get their opinion of the data which we had collected, a draft that we have made, and these people have made suggestions, and finally the guidelines had come out. And these are the Indian recommendations on Indian guidelines on hypertension, third edition. It says that 30 to 35% of hypertension patients are detected to have coexisting diabetes mellitus. This is what was documented, and these are the from the various studies that had been done all over India. They have found out, and they have quoted that this 30 to 35%. Yesterday you must have listened to speakers saying that almost 60 to 75% of diabetic patients are hypertensive. So this is our evidence-based guidelines and clinical experience. We see more patients of hypertension in diabetics than what is recorded. Similarly, the incidence of hypertension is 1.5 to 2 times greater in patients of diabetes as compared to non-diabetics. This is a very well-known fact, and this has been documented in the guidelines. In patients with diabetes, blood pressure target should be less than 150 by 80 millimeters of mercury. How did this controversy come into being? When these guidelines were being published in January, in November, the ADA came out with this figure. First it was recommended 140 by 80 by ADA, but in November 2012, they came out with a guideline that 140 by 80 is not a doable feature, and that's why they raised this level to 150 by 80 millimeters of mercury, and that is why the Indian guidelines on hypertension came out with this figure of reaching goal to 150 by 80 millimeters of mercury in patients with diabetes. And then you came out the guidelines of evidence-based guidelines and the ISH and the IHS, Indian Society, International Society of Hypertension, and American Society, ASH, came out with the recommendations. So they have ultimately come down to 140 by 90. So you must be wondering how this figure came, and that's the way it has come. In November 2012, ADA came out with this figure, and then it has again gone back to 140 by 80. And the drug selection in hypertensive patients with or without major conditions, hypertension and diabetes, the first drug of choice that was recommended in these guidelines was ACE inhibitors or ARB. In black patients, it is acceptable to start with CCB or A. So this has come in the guidelines. This table has come. Add second drug if needed to achieve a BP of less than 140 by 90 millimeters of mercury. Whatever has come out in 2014 guidelines has already creeped into the Indian guidelines of hypertension, and CCB or thiazide diuretic can be added as second line drug. In black patients, if even starting with CCB or thiazide and adding ARB or ACE inhibitors to reach to the goal. If the third drug is needed to achieve BP, the alternate second drug should be thiazide or calcium channel blocker. And this is the A-level evidence in the ADA position way back in 2002 that patients with diabetes should be treated with a diastolic blood pressure of less than 80. Now things are changing, things are evolving, evidence has been coming, but what about the evidence? Then the initial drug therapy may be with ACE inhibitors or ARBs, beta blockers or diuretics. Additional drugs may be chosen from these classes or other drug classes. Why so many drugs? Because as you know, and as I will come down in the mentioned in Indian guidelines on hypertension, we know that one single drug cannot control the blood pressure, and that's why they said you can add other drugs. And that's why the concept of combination therapy has come. Blood pressure should be measured in each visit of the diabetic patient, and the procedure for measurement is the same as in ordinary hypertensive patient. So important thing, when you see a diabetic patient, it's a must every time you see a diabetic patient, blood pressure must be taken. This has been put into the guideline. In diabetic population, it is imperative to measure blood pressure, supine, sitting and standing position to exclude the possibility of autonomic neuropathy. You will see that every statement that has been made by the Indian guidelines on hypertension has been made with thought and made with experience and with evidence. Lifestyle measures is important, and regular exercises form the basis and are applicable at all stages of hypertension. Not only will you detect, but whenever you see the patient in the follow-up. Coexistence of diabetes and hypertension leads to increased cardiovascular morbidity and mortality. The progress of type 2 diabetes in India is increasing at a very fast pace. This is likely to also contribute to a significant burden of hypertension. So these are the trials that were cleaned from, and these were put into the guidelines. We had gone through all these guidelines before putting them into the guidelines for blood control of hypertension. UKPDS, HOT, then ESH, ESC guidelines 2007 were noted, where no definitive substantial data was available. It has been proved that it is useful and effective to treat hypertension in people above the age of 65. The evidence-based guidelines has talked about controlling blood pressure even at the age more than 80 years. So this was put in the Indian guidelines of hypertension, where they talked about the usefulness of controlling blood pressure above the age of 65. It has been observed that to effectively lower the blood pressure, a combination of 2 or more drugs is required for controlling this blood pressure to the target levels which has been recommended. And the ACE inhibitors and ARBs are the first drug of choice. CCBs have also been shown to be useful, and then they can be combined as a useful combination with the ESCOT trial. And beta blockers mask the hypoglycemia, are failing into disrepute in ordinary hypertensive. At a time we thought of not even mentioning beta blockers, but then sane prevailed, and then they have said that beta blockers, newer beta blockers can be used, and beta blockers can be used post myocardial infarct where the patient has coronary artery disease. And newer beta blockers has been recommended. Alpha blockers can also be used as an adjunct. And the ECCOT trial has shown benefit of effective BP control in diabetic patients. It was observed that to prevent one stroke, it requires to treat 89 patients with intensive therapy for a period of 5 years. Most important, hypertension has to be controlled to prevent stroke. So that has been recognized. The ADVANCE and INVEST trial was also taken into consideration for microvascular complications and kidney complications and the eye complications. And the therapy, and this is what was mentioned in the guidelines, that the therapy and the targets need to be individualized for each patient depending on age, comorbid conditions, cost factor. In our country, it is very, very important. Dr. Samar Banerjee talked about the cost factor, ethnic factors, so socio and socio-psychological factors. So very, very important. All this has to be taken into consideration before and continuing the therapy for hypertension, because it's a lifelong treatment. So what is the essence of the various guidelines that I have talked about? Guidelines are necessary because they have taken into consideration evidence-based guidelines which has come out in 2014. Hypertension is an increasing in diabetic population. People have quoted more than 60 to 70 to even 75% of diabetic patients having hypertension. ACE inhibitors and ARBs are drug of choice because these are the drugs which reverse kidney disease. It has been documented it reverses microalbuminuria. So it reverses kidney disease. Mercury manometer is discouraged because of the toxicity, and that's why in future you will see all over the world mercury manometer is being discouraged, and we have put it into our guidelines that do not use mercury manometers. Ambulatory blood pressure monitoring is being encouraged increasingly, and some of the guidelines have even mentioned of doing ambulatory blood pressure monitoring in patients before starting therapy. Combination therapy for hypertension is recommended, it is must. Microalbuminuria is reversible with treatment. CKD should be detected early in diabetic hypertensives. Vascular complications in diabetic hypertensive, micro and macrovascular complications are more common. Multiple antihypertensives are required for control of blood pressure, and hence combination therapy is recommended. And to conclude, all the guidelines says a very important statement that although these guidelines provides evidence-based recommendations for the management of high blood pressure and should meet the clinical needs of most patients, these recommendations are not a substitute for clinical judgment, and decisions about care must carefully consider and incorporate the clinical characteristics and circumstances of each individual patients, which the Indian guidelines has mentioned about various factors. Thank you.